The surgical technique recommended by the Difficult Airway Society for the management of the can't intubate, can't oxygenate scenario is the rapid 4-step technique. The equipment required is a size 6 cuffed endotracheal tube, blunt tracheal hook, and a size 20 surgical blade. The size 20 surgical blade is used because it is wider than a size 6 endotracheal tube and because it has a wide leading edge which leads to a significant sensation of loss of resistance when the airway is entered. The classical description is for the anaesthetist to stand at the patient's right side if he or she is right-handed and at the patient's left side if he or she is left-handed. However, the technique also works well with the anaesthetist in the position they are most familiar with, behind the patient's head. The 4 steps are palpation, incision, traction and intubation. Palpation. The cricothyroid membrane is most easily palpated by moving downwards from the thyroid prominence in males and upwards from the cricoid prominence in females. Once the cricothyroid membrane has been located, the airway is stabilized between the anaesthetist's fingers. A horizontal incision is made parallel to the cricothyroid membrane. This incision is a single stabbing motion made perpendicular to the skin. It goes through skin, subcutaneous tissues and the cricothyroid membrane in a single movement. A loss of resistance or pop may be felt when the scalpel enters the airway. Once the scalpel is in the airway, it is stabilized in position as demonstrated. The tracheal hook is passed into the airway with the scalpel still in place. The hook slides along the scalpel blade to guide it into place and to avoid the formation of a false passage. Once the tracheal hook is in position, the scalpel is removed and safely put to the side. The hook is then turned 90 degrees and traction is applied in a caudad direction. This axis resembles the axis of the laryngoscope handle during routine laryngoscopy. Finally, the size 6 endotracheal tube is passed through the wound using the bevel to assist intubation. The cuff is inflated and position of the endotracheal tube is confirmed using conventional techniques.